Hello everyone, welcome to the day 3 of our challenges series for NEET PG. Let's revise dermatology today and I'll try to complete most of the dermatology, if not all, within 25 minutes. Let's see how it goes. Let's begin without any further discussion. So, beginning with first topic for dermatology, we have in our notebook cells and layers of epidermis. Just need to remember the five layers of epidermis: basal, spinosum, granulosum, lucidum, and corneum. Remember, granulosum contains lamellar granules, that is why it appears granular. Basal has the most important thing, that is melanocytes, and spinosum, because of keratinocytes, appears spinous in nature. Other than that, you need to remember that corneum is a dead layer and lucidum is mostly thick and it's present only in thick skins like your palms and insoles. So in cells of epidermis, what you need to remember is keratinocytes, melanocytes, and Langerhans cells. So keratinocytes are basically the ones which produces keratin because and they contain Odland bodies. In melanocytes, you need to remember that they protect you from UV rays and it is present only in stratum basal. And Langerhans cells are antigen presenting cells of skin and hence form first line of immunity. They contain Birbeck granules. Here we have Odland bodies in keratinocytes. Here we have Birbeck granules. So important things in melanocytes and Langerhans cells is their markers. Melanocytes has melanae as the name suggests and HMB45. However, CD1A and 207 and S100 are part of Langerhans cells. Remember, S100 is part of both Langerhans cells and melanocytes. There is a HLA marker also for Langerhans cells, which is HLA-DR. One more important thing you need to remember is Langerhans versus Langhans. Don't confuse them. Langerhans is your antigen presenting cells. It may be present in skin, cornea, or other first line mucosal defenses. However, Langhans is a giant cell which is seen in granuloma formation in TB and other stuff. Okay, you'll have all this giant cells formation that happens in Langhans cells. Okay, moving on to the next important thing, the derivatives of epidermis. Remember that M are formed from N. So Merkel cells are your subcutaneous receptors which will be talked in touch receptors and other receptors which form touch, vibration. All this will be discussed in physiology. So just remember, Merkel cells is present in subcutaneous layer or the superficial layer, and hence I have included here. NCC, which is neural test cells, give rise to M, which is melanocytes and Merkel cells. Keratinocytes is ectoderm, and hence you can see that in outer layer, which is your spinosum, and Langerhans cells is mesodermal, LMNO. So L are formed from M, which is mesodermal. Okay. Moving on to next, you need to remember the investigations which are routinely taken part for diagnosing skin disorders. There will be three types of biopsies also. So, for example, if you have epidermis, dermis, and subcutis here, if you want to have superficially disorders which only involve superficial surface, then we call it as shave biopsy, just like shaving. And then if you want to diagnose a bit deeper disorders, then we have punch biopsy. And for the disorders mainly present in subcutis, you will have to get a most deepest biopsy, which is incisional biopsy. So incisional biopsy, you are getting it done in the disorders where deeper substances are involved. For example, panniculitis or vasculitis, because vessels and subcutaneous fat are present in that layer. Okay, and superficially you need to remember some diseases for share biopsy, which is psoriasis, lichenoid disorders, or any keratosis, eczema. All this will come under share biopsy. Rest will be done by punch biopsy. Then we have potassium KOH mount, which will be used for fungal disorders, and patch test, which will be done for atopic dermatitis. Moving on quickly to the vesiculobular disorders, I think you all know the main classification. You will be having either intracorneal, which is within the stratum corneum. Then we have intraepidermal, and we have immunobullous disorders with intraepidermal bullae and immunobullous diseases with subepidermal bullae. So these are the most important thing for immunobullous disorders with intraepidermal bullae. We have all the pemphigus group. There is one important thing there, which is Phagocelvagium, which is due to it is a variety of Brazilian pemphigus foliaceus, which happens endemically in Brazil. Other than that, there is Pemphigus vulgaris, vegetans and foliaceus. All the pemphigus group comes under that. And there are other, one more important thing will be your Hailey-Hailey disease. However, in subepidermal bullae, you have the pemphigoid group, which is bullous pemphigoid and cicatricial pemphigoid. Other than that, you have one more important thing, which is dermatitis herpetiformis. Then you need to go ahead and remember the direct immunofluorescence patterns. In direct immunofluorescence patterns, you need to remember only three important ones, which is linear IgA disease, where you will have a very dark image and then there will be deposition of substance like linear deposits will be seen along the basement membrane, because that is where the involvement pathology is. So this happens in linear IgA disease. However, there is one more important thing, where in dermatitis herpetiformis you will have deposition of same IgA ones, but this was a bit linear. Okay, there will be granular deposits, but if you consider this as the basement membrane, then it will have granular deposits within the dermal papillae. The papillae are the ones which are projecting into the epidermis. So this happens in dermatitis herpetiformis. These are the important two ones, and the last important thing will be your fishnet pattern or the basket view pattern, which is both IgG and this complement C3 deposition, which happens in a fishnet kind of pattern. So this will be your fishnet or basket view appearance for pemphigus vulgaris. Okay, three important disorders you need to remember in vesiculobullous disorders are pemphigus vulgaris, where you have histopathologically row of domes and fishnet pattern on direct immunofluorescence. Then bullous pemphigoid, you need to remember that in bullous pemphigoid we have deeper involvement. That is because the targeted structures in bullous pemphigoid is your hemidesmosomes, which are present beneath stratum basale. Okay, so hemidesmosomes are present here, which is the targeted site in bullous pemphigoid. However, in pemphigus vulgaris, the site of target is the desmosomes, which occurs within the cells, which are present within the cells of epidermis. That is why the involvement of blisters is present in within the epidermal layers, while in hemidesmosomes it is in bullous pemphigoid it is present beneath basal, stratum basal. This is important because these will present differently in each disorders. Then we have the last important one in this category, which is dermatitis herpetiformis, where we have the pathology within TTG, and hence this is present in the dermis, layer of dermis, which will be deeper down. So arrangement wise, pemphigus vulgaris is the most superficial, bullous pemphigoid is beneath the basal layer, and involvement of dermatitis herpetiformis is within the dermis. Moving on to the next one, we have blisters, which is classification of blisters into flaccid and tense, If you do a classification like this, then you will be easily remembering all the stuff. I'll just give one point of each. So just remember classifying them into flaccid and TENS will definitely help you. So whenever you see a image of a blister which has ruptured and there is only dead skin left with the exposed red skin, then that is a flaccid blister. However, in TENS blister, you will see a persistent blister which has not yet ruptured. Because it is very difficult to rupture, it is present deeper down. So in genetic, you need to remember Hailey-Hailey disease and erythema bullosa simplex. So if you know, you might know erythema bullosa simplex, erythema bullosa junctionalis and dystrophicaans are all part of genetic blisters. So if EBS is part of flaccid, then EBJ and EBD will be part of TENS blisters. So that's all from TENS blisters. You have two genetic disorders here, and in acquired part of TENS blisters you have bullous pemphigoid, dermatitis herpetiformis and LIGA. So I've already told the DIF pattern of dermatitis herpetiformis and LIGA. In clinically LIGA presents a string of pearls. Okay, and dermatitis herpetiformis, the most important thing will be to remember its association with celiac disease. Bullous pemphigoid, you need to remember whatever I have told, and there is itching also, and this is mostly present in elderly. Hailey-Hailey disease, nothing much to remember except for fissures and flexural surface. Okay, in acquired part of flaccid blisters, which is the most important part, I believe, is your most important disease, which is pemphigus vulgaris. Vulgaris because it presents throughout your body, so it's widespread. And there is also mucosal involvement. So if they send you a picture of oral mucosal involvement, then it is pemphigus vulgaris. Then we have 10 staphylococcal scattered skin syndrome and pemphigus foliaceus. One thing to remember in pemphigus foliaceus is mucosal surface is not involved and it is scaly or seborrheic. Okay. 10 toxic epidermal like epidermolysis necroticans. I'll talk it later. Staphylococcal scattered skin syndrome is a part infectious disease which usually presents in child, and it is also scaly or seborrheic here also. But remember that there will be no immunofluorescence test positive in this. Okay, so I'll talk about SJS and 10. So whenever there is less than 10% involvement of mucosal surface, then it is SJS. Greater than 10% will be 10. 10 to 30 will be our SJS 10 overlap. So remember that 10 occurs mainly in elderly and it is spontaneous usually. SJS contains a viral predome, URI like viral predome, and it presents mainly in children. One more important thing you need to remember are the drugs which will cause these both disorders, which will be the most important of them will be penicillin. If you remember penicillin, if they want to test you, they will usually test you with penicillin, but there is other CNS drugs which will be phenytoin and barbiturates. Then the most common drugs which are also part of fixed drug eruption is your NSAIDs. Then you also have sulfonamides, which are another antibiotic group which might cause, along with penicillin, which might cause SJS and 10. And there is also one more important HLA association, HLA B1502. Okay. There are some prognostic scores, I don't want you to remember that, it's purely for INI point of view, which might come as a bouncer. Other than that, hypopigmented patches, you need to remember PANV, PAN-V. Okay. In PAN-V, we have from N, nevus acromicus and nevus anemicus. P is your piebaldism, A albinism, and V vitiligo. I want you to remember the important disorder images, how they will come. Anemicus and acromicus, the only important differentiation is diascopic test, where acromicus, as you know, will be congenital and they don't blanch on diascopy. Anemicus, however, is because of, as you can see, just remember that anemicus sounds more like anemia, so it will be developmental, but they will blanch on diascopy. Okay. Other than that, piebaldism will be your Indira Gandhi kind of image, where part of forehead and along with hair will appear white. And then there is albinism versus vitiligo, which is important purely because albinism is present at birth directly, because it is a inherited disorder, autosomal recessive. Then it is because of deficiency of tyrosinase. However, vitiligo is not developmental. It's not congenital. It is developmental, and it has hypomelanotic lesions with hyperpigmented borders. This is because there is absence of melanocytes at that particular region. Then we have Cobnus isomorphic phenomenon positive here. Response of albinism to treatment is bad. However, we have PUVA, which for vitiligo. Moving on, you have a classification for hypopigmented disorders. So if it is present on the face, how do you approach, and how do you approach if it's present on the tongue? So face wise, you need to see if scales are there or scales are not there. If scales are not there, then it is directly indeterminate leprosy. As you know, leprosy does not form any scales or anything. So just remember that indeterminate Hansen's or leprosy will have endemic child from endemic region with normal sensation and no thick nerve, because it is indeterminate. Okay. However, you need to remember that in scaly disorders which occur on face is your closest diagnosis for indeterminate leprosy, which is pityriasis alba. Here the kid will have history of atopy, asthma or anything which might be given, and there will be recurrence given in the question. And there is pityriasis versicolor, which is mainly occurring in the peripheral region. And pityriasis versicolor, what you will remember is your spaghetti meatball appearance, and the important thing will be its appearance will be on chest and back mainly. And trunk wise, what you will remember is the same classification. Scales are present or scales are absent. If scales are absent, then it will be leprosy except indeterminate forms. So if it is not indeterminate, then we will have thick nerves, palpable nerves, or sweat and sympathetic system will be lost. So sweaty loss and sensory loss will also be there. Other than that, PKDL, which is post Kalaza dermal leishmaniasis, here there will be no sensory loss, no sweat loss, and the child will be from endemic state with the history of prolonged fever. However, one more important thing you need to remember when scales are present is your pityriasis versicolor. So pityriasis versicolor can present in both face and trunk. So other than that, there will be depigmented lesions which I have talked about already. The important ones being albinism and vitiligo, and the one which has the regular margin will be your contact leukoderma. So in diseases which are presenting developmentally, vitiligo will have regular margins. Vitiligo will have irregular margins, as I have already told, with hyperpigmented borders. However, contact leukoderma will have regular margins. So you just have to remember the cause of contact leukoderma. They have tested this, and hence I want you to remember two important things when where there's bindi leukoderma and people who wear rubber slippers. So in bindi leukoderma, remember paratertiary phenol (PTP) is a causative agent. However, MBE, which is monobenzyl ether, MBE sounds like rubber, MBE rubber. So this monobenzyl ether is the causative agent in rubber slippers. So after that, you need to just move ahead with hyperpigmented lesions, and the same approach will be followed if it's present on face or if it's present on trunk. If it's present on face, is it congenital or acquired? In congenital, you have all your melanocytic conditions, like nevocytic conditions, like melanocytic nevus or nevus of Ota. However, in acquired, you have either your drug related, which are FDE and melasma, or your infection related, Chicksain. So melasma will be related with pregnancy or OCP. FDE will be presented will be associated with NSAIDs mainly, and there will be lips. They will give an image of lips basically, or perioral region. And Chicksain will also have the similar appearance, where there will be involvement of lips or nasolabial bridge or the nose. So you also have to remember there will be history of fever and joint pain. However, in melanocytic nevus of aorta, you need to remember it is there will be scleral involvement, classical. There can be no other answer other than that. However, there will be unilateral malar involvement along with that. So sclera, both of them appear blue. Nevus in nevus of aorta. In melanocytic nevus, you need to remember that it is black and it has hairy. It will have persistent hairs also along with the lesion. So in fixed duct eruption, you need to remember NSAIDs as the cause. All antibiotics, most of the antibiotics, the broad spectrum ones, and all your CNS drugs like barbiturates and other anticonvulsants. Other than that, if it is occurring on trunk, how will you classify? If it's on the shoulder, lumbosacral, and flexural. So lumbosacral is nothing but your Mongolian spot, which is normal finding in kids, neonates basically. No, they might not ask you. However, flexural you need to remember your most important one, which is lichen planus, which is 5 piece, purple plain top, polygonal papule pruritic. Shoulders and upper back is the one which is much more difficult to differentiate. But if there is hair on shoulder, then it is Becker's nevus, and it happens after puberty. So it's brown kind of appearance with hair. If it's blue, then comes your nevus of Ito. However, there is no after puberty appearance or something. It is just congenital. And there is one more thing, which is Urticaria pigmentosa, where there is brown patch on in a child in trunk. So you need to remember these certain disorders in dark lesions. Then you directly move to the next important thing, which is your infections. In infections, we have dermatophytosis. You need to remember each of the causative agent. I would rather ask you to remember among them the most important one are the Tinea capitis, and the drug of choice for everything. The drug of choice for most of them will be oral griseofulvin. Just remember that. And other than that, your causative agents, trichophyton, microsporum and epidermophyton. Microsporum M does not affect N, so there is no affection of nails in microsporum, and epidermophyton does not EFGH, so it does not affect hair. Trichophyton affects all skin, hair and nail. So other than that, what do you need to remember as each of the causative agents for each of them? But remember that in Wood's lamp, if Tinea capitis they give, it will be bright green in appearance. Erythrasma, however, will be your coral red. And Tinea versicolor will be yellow. These are the three most important things you need to remember under Wood's lamp. Other than that, you need to remember the 3 disorders of Corynebacterium lesions, which are pitted keratolysis, mycosis axillaris, and erythrasma. Erythrasma, as I have told you, if they want to give an image of axillary hair under Wood's lamp, it is erythrasma, which will be coral red. Then mycosis axillaris, they will give an image of axillary hair which will have beaded studded appearance with yellow color follicular substances where there is infection by Corynebacterium. Pitted keratolysis, they will give either palm or sole, which will have pitty layers on the surface. Other than that, you need to remember the differentiation between impetigo contagiosa and bullous impetigo. In impetigo contagiosa will be present same like bullous impetigo, but the important thing to remember is it is caused by Streptococcus more than Staph aureus. Bullous impetigo will be caused by Staph aureus mainly, and hence it will complicate into Staphylococcal scaldicin syndrome, as I have already told before. A complication of impetigo contagiosa is because of the causative agent Streptococcus, post-streptococcal glomerulonephritis. Then erysipelas versus cellulitis, the important thing you need to remember is the Melian-Ear sign, where there is non-involvement of pinna because of the absence of deeper subcutaneous tissue in erysipelas, where there is lymphocyte positive also. So erysipelas will have streptococcal infection, however cellulitis has overlap between streptococcal and staphylococcal. Then all your eczema you need to remember. And then oral white lesion, just remember if they give you a white orally lesion which can be wiped off, then it is candida. They'll also give history of immunodeficiency. However, if it can't be wiped off, then you need to see if it is lacy pattern and if it has association with hepatitis C virus, then it's lichen planus. However, if they don't give anything like that, or they just give you a risk factor of EBV or tobacco chewing or anything like that, then it will be leukoplakia. And other important thing will be your HPV and its association with malignancy. So just remember, whenever there is malignancy, then it has to be HPV 16 and 18. Penile carcinoma, cervical carcinoma, anal carcinoma. Okay, where 16 is more important. However, for cervical carcinoma, 18 HPV 18 is the more prevalent one. Then we have the most important mnemonic for the warts, which is DSP cell, where we have the types. Just remember, C is the one which is most confused by people because the rest of them are rarely asked. It will be deep plantar, superficial plantar, plain vault. So verica plana. So these three are caused by 1, 2, 3, 3 more than 10. Then there is the most important one which is commonly confused is the C. So common wart is basically verica vulgaris. As I told you, vulgaris means widespread or common. So verica vulgaris is caused more by 4, but however 2 is the more important cause. So 1, 2, 3, 4. Then we have epidermodysplasia is caused by 5 and 8. Then your 6 and 11 caused by which causes laryngeal and anogenital warts, and Butcher's warts, which is HPV 7. Then other important stuff are the treatment. In pregnancy, just remember that treatment of choice will always be cryotherapy over drugs. In drugs, what you can use is your trichloroacetic acid. So just remember this thing. And if there is a image where there has been a beaded heaped up appearance in anal region, then they will usually want you to answer Bushkill-Lowenstein tumor, where again cryosurgery is the important thing. Then leprosy wise, you need to study everything. Just remember, in leprosy, as the lesions go from tuberculoid to lepromatous, that means there is deficiency of immune system. So the infective agent overwhelms the immunity system, and hence it will be more severe and high number of lesions in lepromatous type. And where tuberculoid type, where there is good immune response, there will be just a single area, single nerve thickened, sweating sensation absent, or single lesion, or some few lesions, saucer shape. Everything will be in tuberculoid. So just one important thing will be your saucer shaped in TT. In BT there is satellite lesion. In BB there is Swiss cheese or inverted saucer. Then in borderline lepromatous also there is punched out or Swiss cheese. And in LL there will be variable presentation, multiple lesions will be there. So just remember, they will be having glove and stocking anesthesia. However, here only one, as I told you, only one thickened nerve will be palpated, and only skin sensation over that region will be lost. Other than that, you need to remember type 1, 2, 3 and 4, type 1, 2 and 3 lepra reactions. And just remember that 1 will be associated with type 4 hypersensitivity, 2 will be associated with type 3 hypersensitivity, 1 plus 4 is 5, 2 plus 3 is 5. So type 1 will be present more in the tubercular BT or BL kind, and type 2 will always be in lepromatous variants, LL or BL. So LL or BL means they will always present with multiple skin lesions. Along with that, all these lesions on lepra reaction will present with more newer lesions. However, in type 1 lepra reaction, existing lesions will be having ulceration. Okay. Then is your tuberculosis of skin. Just remember, scrophaloderma and lupus vulgaris are the common conditions in children and adult respectively. And for another important thing you need to remember is the tuberculous canker happens in individuals who are exposed to TB for the first time. So other than that, you need to remember the centripetal and centrifugal rashes and rashes after fever on the days respectively. The mnemonics I have respectively mentioned in my notes and the images also. Then the most important thing will be your STD. STD, how do you approach this? I'll be covering later on, but just remember this table where there is painful or painless ulcer. Primarily, you go ahead investigating with ulcer. If it is multiple and painful, then it has to be either cancroid or herpes genitalis, where herpes genitalis does not form any abscess. Cancroid, being a bacterial infection, forms abscess, and in cancroid, the causative agent Haemophilus ducreyi will present on microscopy under gram staining as school of fish appearance. However, herpes genitalis, being a viral infection, presents with so you can diagnose it on CBNAT or PCR. However, if the ulcer is single and painless, you need to investigate the lymph nodes. So lymph nodes, if they are multiple bilaterally symmetrical, then it is definitely non-abscess forming and it has to be syphilis, which is diagnosed on dark ground microscopy. If it is unilateral and bubo formation, then it has to be lymphogranuloma venereum, which is also diagnosed on CBNAT. And if it is forming pseudo bubo kind of appearance, then it has to be granuloma inguinale, which has safety pin appearance. Then is your syndromic management of STI kits. You remember that mnemonic: go green with blue rivers and yellow birds for the color coding and the respective conditions which are treated by that. And then there is your important update of new kit which I have mentioned in our notes, supplementary material, just go through that also. Then you have scales and pustules. So if you hear something like pustule, then it has to be either three most important conditions, which will be mycosis fungoides or infectious lesion which might be secondarily causing a reaction like in dermatitis herpetiformis, or a direct this manifestation which is impetigo. Then there is psoriasis, either pustular or normal variant. So other than that, scaly conditions, you have psoriasis, seborrheic dermatitis and pityriasis rosea. So just remember these three things, and in pityriasis rosea you have to remember the collarette of scales appearance. So like here collarette, as you can see there will be thick collar in the lesion, that you need to remember. Then going next, you need to remember are the treatment in each type of psoriasis. Just remember three important ones in that, where whenever a pregnant woman presents, then it will be the case scenario will be of impetigo herpetiformis, where you will have to give systemic steroids. However, there will be another important manifestation where just the patient presents with arthropathy, psoriatic arthropathy, where you will have to give methotrexate. And in gutted psoriasis, where there will be widespread lesions throughout, you need to give macrolides, antibiotics, which because the skin lesions look like they are infected. And another thing will be your Kobnos phenomenons, which you need to remember. Then you need to remember the red lesions on face will be your congenital ones or acquired ones. Congenital ones are the port wine stain, and if there is association with seizures, then you have to suspect Sturge-Weber syndrome. In acquired, you have dermatomyositis, SLE, and acne rosacea. Myositis, you need to remember muscle weakness. SLE, remember malar area, sparing nasolabial fold. Acne rosacea, remember malar area involving nasolabial fold, plus there is photosensitivity in both of them, acne rosacea and SLE. So in acne, or talking about acne, you need to remember the most characteristic lesion. If they ask you, then it has to be comedones for acne vulgaris, and grading will be comedones for grade 1, grade 2 papules, grade 3 pustules, and grade 4 nodulocystic. Whenever nodulocystic is there, you have to start systemic oral retinoids. Other than that, everything else will be topical retinoids plus in pustular variant, which is grade 3, you need to remember oral antibiotics is also given. Isotretinoin is not given orally because it has many side effects. The most important thing will be diffuse interstitial skeletal hyperostosis. However, it is also teratogenic plus hepatotoxic. Other than that, for the adnexal thing, you need to remember the important components being sweat glands, sebaceous glands, hair and hair follicles. You need to remember alopecia, the most important tested questions. In alopecia, it has to be either scarring or non-scarring variants. If they give you scarring alopecia, then you have to see if they have given a child with pus formation, then it has to be Kirion or Favus. In Kirion, it will be boggy, tender appearance where there is inflammation. In Favus, there is yellow scrotal appearance where there is lack of inflammation. And then there is in scarring, we have lichen planopilaris where there is footprint in snow appearance, and then there is DLE bar SLE where there is carpet taxine. However, in non-scarring, you need to remember the rest of the stuff like your Amazon telogen effluvium and androgenic alopecia, where there is diffuse involvement, and patchy involvement is seen in syphilis, trichotillomania, where the patient keeps plucking from the non-dominant region where it is easily accessible. Then there is tinea capitis, and then there is alopecia areata. Then you need to remember in sweat glands some important diseases. Most important one I would ask you to remember is your Fox-Fordyce disease, where there is apocrine involvement, and hidradenitis suppurativa, which is also apocrine involvement. However, miliaria is eccrine involvement, eccrine gland involvement. Then in nail abnormalities, you need to remember three important stuff, which is pitting, seen in psoriasis mainly. However, it's also seen in atopic dermatitis and alopecia areata. Then you need to remember koilonychia, which is a manifestation of iron deficiency anemia, and pterygium. Pterygium is like your conjunctival pterygium also, similar to that. Conjunctival pterygium will be like this, and for nails, pterygium will be like this. So pterygium is basically a wing kind of thing, which is seen in lichen planus. Another thing will be your knee slime, which is also seen in arsenic poisoning, which will be discussed in FMT. So these are important nail abnormalities you need to remember. Then you have your atopic dermatitis also, where you have to remember your Hanifin-Rejke criteria is used to diagnose that. Other important stuffs will be your drugs and dermatology, where most of this there is nothing much to explain. You just have to go through that. And the most important things I would ask you to go through will be drug-induced acne and drug-induced psoriasis, which drugs cause what, and all the drugs of choice I have compiled under one section. The most important one will be your tinea capitis, where that's oral griseofulvin. However, in all other tinea, there is terbinafine, which is the drug of choice. Then you need to remember the drug-induced pigmentation. The most important will be your arsenic, which presents with raindrop pigmentation. And another important thing will be your bleomycin, which will be presenting with flagellate pigmentation. Then you have the others, which is your umbilicated lesions, which have been tested in INI-CAT frequently. Then you have erythroderma is seen in what conditions, and seborrheic distribution is seen in what conditions. So erythroderma, you have your ID scalp, refer to the notes, and lesions following seborrheic distribution will be your seborrheic conditions. Umbilicated, just remember disseminated cryptococcosis, molluscum, cutaneous penicillosis, and histioid leprosy. All of them causes umbilicated lesions, all these infected conditions. Okay. Other than that, you need to remember all the erythema which I have clubbed in under one heading, and among them erythema nodosum is one important thing, where the association with IBD, pregnancy, Drugs like penicillin and sulfonamides which come everywhere, and infections with group A streptococci, salmonella, leprosy and TB. So this is what our dermatology looks like in such a short amount of time. I tried to cover most of it. Without wasting time, I'll just go with yesterday's discussion. You had interscalene approach does not affect which distribution of which nerve. Just remember this diagram where interscalene block is given, where supraclavicular, infraclavicular and axillary is given. Just remember that in interscalene approach, the distribution will be sparing of C8T1, and ulnar nerve is the one which has C7 C8T1 dermatomal distribution. So ulnar nerve is paired in the interscalene approach. What else you need to remember is both infraclavicular and supraclavicular are associated with pneumothorax. Interscalene is associated with sparing of ulnar nerve distribution and Horner's. And axillary block, you need to remember that musculocutaneous nerve sparing will be there. Other than that, next question was tracheal intubation to assess ventilation is indicated if PaO2 is less than 60. Okay, just remember that if it's less than 60, then tracheal intubation is indicated. Next, potentially reversible cause of cardiac arrest. You all know will according to that guideline where you see ACLS guidelines, you see whatever is reversible and all, but if it is not reversing despite your continuous CPR or anything, then you have to suspect hypocalcemia in that patient. Okay. Next, neonates born to mothers receiving prelocaine. I told you in anesthetic conditions, the only side effect involved among these options was methemoglobinemia. They are given myoglobinemia just as a confuser. Just remember that methemoglobinemia can be presented in fetus in mothers who have been receiving epidural anesthesia. Okay. Then there was one LMWH related question. So this will be, you have to delay it by 12 hours after administering the drug. Otherwise profuse bleeding might occur. So just remember this thing. Then today's questions are quite tricky and I want you to focus and answer in the comment box. Just remember that I have not given any direct question. I want you to identify the lesion and then give me the correct answer. So first of all, what is this lesion? So I'll just give you what is that? A clue for every question. So in this condition, you will see that it is an infective condition, and one more important thing you need to remember for this condition is that it presents with variable forms. This is a cutaneous form of that. Okay, so what you will remember, you just give me the diagnosis, what is the causative agent rather than what is this condition. So I want the causative agent for this. Next important is this lesions, where this is taken directly from Wikipedia. So because there was no high resolution available, I hope you are able to make out the lesions. So just see, this is present in axillary region. So you give me identify this lesion first and tell me what is the treatment for this. Then there is one more condition. So I'll give you a clue. This will be a diabetic patient with frequent exposure to swimming pools. Okay, just give me the causative agent for this and the lesion. Next is this. Okay, I've twisted this a bit. So what is this lesion you have to identify, then give me the causative agent for that. But both of these are not the questions. The question is, the causative agent is closely closely associated with which of the following bacteria or virus. So taxonomically it is closest to which of this. So first you have to identify the causative agent and then you can give this answer. Other than that, I want you to identify this and tell me the mechanism for that. This is a baby, remember that, and you can see that blue appearance is there along with raised papules or nodules. Okay, so I want your answers in comment box. Hope you could make the best use of this session. Thank you.